folks. Welcome to Healing Outside the Box. My name is Jean Tiberio, and I'm a nutritionist and a wellness coach. Today you're listening to episode 279, which is the pros and cons of gastric bypass surgery. Now, this is a major topic, and even skimming the surface might take more than one episode, so it'll probably be a two-parter. But first, oh lordy, do we have some craziness going on in downtown Salem right now. My apartment sits right on the Salem Common, smack in the middle of all the haunted happenings. We are going to get a record-breaking number of tourists this year, for no apparent reason. Someone in my apartment recently looked out the window at all the little goblins and zombies walking around Salem and said, "Hey, Jean, there's just white people down there." To which I said, "Yeah, I know. It's a white people thing." Now, I know I've mentioned this before, but I sometimes look out my window and see a tourist taking a picture of my apartment building. Other people have noticed it as well. That's because my building was the school in the Hocus Pocus movie that came out way back in 1993. I've lived here for exactly 33 years, so I was around for the filming of the first Hocus Pocus. I remember a couple of Disney guys met with myself and another guy from the building. Disney actually gave our landlord an undisclosed amount of money to use the building for the school. But we apartment dwellers got $50 from Disney to take down our curtains. You can actually see my living room window in the movie when they approached the school, so curtains would not do. Since they were schoolhouse windows, they were 108 inches or 9 feet tall. I had to hire someone with a painter's ladder to get the curtains down. But it was all in good scary fun. Now, on the night of the filming, way back, I think it was 1991, my mom and I were trying to watch through my computer room window by ducking our head out just a little bit to watch them film the takes with the kids in the black cat. Here's the thing about cats that they must have known on an intellectual level. They wanted the cat to follow the kids, but herding cats is not an easy thing to do. They would let the black cat out of its cage and used a clicker to try to get the cat to follow the kids. Except that the cat didn't want any part of it and ran down the street at lightning speed, followed by a middle-aged man running down the street at not so much lightning speed. Then they would pull out another cage with another black cat and tried it again. Me being an animal lover and all, I found this very amusing and a little sad for the cat. So we're watching all of this unfold, and then I got a call on my house phone. Remember those? And the voice said, "Hello, the director wants you to please try and keep your head out of the window. We can see you in the shot." Again, very amusing, but a little sad that we couldn't watch anymore. Anyway, back to the podcast. Here we go with the pros and cons of bariatric surgery, with a comparison of the different types of what we now call gastric bypass. First, I'll just go into defining what it is, then the controversy over the subject of sustainability of the weight loss, which will probably be in part 2. The first thing I want to say is that if you're seriously considering this, please speak with a trusted healthcare professional first. It could be a physician, nurse, dietitian, or anyone that has experience working directly with bariatric surgery patients. I wouldn't be surprised if your physician also recommends that you speak to a specialist who is not financially benefiting from the surgery. I was discouraged once to hear from one patient that her team of healthcare people that were doing the surgery were also pushing their own protein drinks that they were making money from. She was so excited to be having the surgery and so desperate to lose the weight that he didn't want to burst her bubble by telling her that I was so pissed at their dubious ethics. And speaking of ethics, I highly recommend that you are seen by a respectable psychiatric professional to make sure that you're going into this with a clear-eyed view of all possible consequences. You may want to consider seeing a therapist outside the surgical team with no skin in the game. But let's backtrack and describe the different types of gastric bypass surgeries. The different types of surgery recommended will be at least partially determined by the initial weight. The first thing to evaluate is a person's BMI before any recommendations are given as to the type of surgery. Now, the calculation for your BMI is as follows, and I'll put this in the show notes as well. It's your weight in pounds divided by your height in inches squared. When you get that number, multiply it by 703 to get your BMI. You should have a BMI of 40 or more before surgery is recommended. If your BMI is between 35 and 40, they are usually hesitant to go forward with the surgery unless you have an obesity-related condition, say diabetes, heart disease, or even severe sleep apnea. There's also a maximum weight for gastric bypass surgery, and it's 450 pounds. All right, so I'll give you an example. Say for a weight of 240 pounds, and let's say the height is 5 feet 10 or 70 inches. So the BMI will be 240 divided by 70 times 70, which is 4,900. The answer is 0.049. Multiply that by 703, and the BMI is 34.4. This person would not qualify for surgery. The BMI needs to be at least 35, but closer to 40. Now let's say this person weighs 280 pounds. 280 pounds divided by 70 times 70, or 4,900. And then when you multiply that by 703, you get 40 for the BMI. And that means that person would qualify for gastric bypass surgery. Okay, now here are the different types of surgeries. The most common procedure is called the Roux-en-Y gastric bypass. This used to be called the Billy Roth 2, meaning there was a Billy Roth 1 that wasn't as severe. This gastric bypass leans more on restriction. In other words, a much smaller stomach. The stomach that is left immediately after surgery is about the size of 4 grapes. I kid you not. So in the Roux-en-Y, most of the stomach is removed, along with the entire top third of the intestines. Now, the small intestines is broken up into 3 parts, and each part has functions. The first third is the duodenum, which is literally cut away with this surgery. So they'll hook up the much smaller stomach to the second third of the intestines, which they call the jejunum. All parts of the intestines are important, but the first third specifically secretes hormones from the pancreas that help digest the food and also help absorb minerals like iron and calcium. And all of this will be negatively affected by the surgical removal of this portion of the small intestines. The less severe Billy Roth 1 takes away some of the intestines, but less of it. It is generally not preferred now because there is less weight loss, and most of the time, the patient will remain obese. They'll lose some weight, but often gain back a lot. I'll have more to say about risk and reward in part 2. But for now, I'll just describe what they do. Okay, the next type of surgery is called the sleeve gastrectomy. With sleeve gastrectomy, about 80% of the stomach is removed, which is a lot, and it leaves a long tube-like pouch. This gastric sleeve is ideal for patients who do not want to deal with the malabsorption side effects, like vitamin deficiency symptoms and diarrhea. And usually they don't need to lose more than 130 pounds. The gastric bypass is generally recommended if the person needs to lose, say, 150 pounds or more. This sleeve gastrectomy being a simpler operation with almost as good results as the bypass, has become the preferred choice for many physicians who maybe see cutting out your intestines as just too radical a thing to do. The vertical sleeve is generally considered the safest in terms of serious side effects. However, the risk of dumping syndrome is still a real one with this procedure because the stomach can get too full and literally dump food into the intestines. I'll get into dumping syndrome in a minute. Now, the third type of surgery is called the biliopancreatic diversion with duodenal switch. This can actually be broken down into two different surgeries. It's a more complicated surgery and more extreme. It involves more cutting and more stitching and takes out or bypasses more of your intestines than other procedures do. This makes it more riskier for complications, both during the procedure and afterward. So this might be considered for someone with a BMI of over 50 and major complications like insulin-dependent diabetes that might dramatically cut someone's life expectancy. This duodenal switch is an operation that modifies your stomach and your small intestines. It removes most of your stomach and it shortens the path that your food takes through your intestines by a great deal. So it severely restricts the nutrition your small intestines can absorb through your food. So this makes it a malabsorptive procedure. So the duodenal switch reduces the size of your stomach by say 60 or 70% versus up to 80% with the Roux-en-Y bypass. But it also bypasses about 75% of your small intestines versus only about 30% with the Roux-en-Y. So you can run into all types of deficiencies and will never be able to stop taking iron and other multivitamin supplements. The fourth and least invasive weight loss surgery is the adjustable gastric band. This is also referred to as the band, and it involves an inflatable band around the upper stomach that produces a smaller stomach pouch. The intestines are not cut out. Because it is the least invasive, the outcome results in reduced recovery time and fewer potential complications. Okay, now I'm going to lump all of the side effects and surgical risks together and just mention them here. In part 2, I'll get into which ones might be a serious complication and which ones can be treated. Just keep in mind, and I've said this enough, but the more severe the surgical procedure, the more risk of serious side effects. Okay, the surgical risks. This is true about a lot of surgeries. They are wound infection, excessive bleeding. Adipose tissue has a lot of blood vessels, which the surgeon will be cutting through. There could be reactions to anesthesia, possible blood clots, the usual surgical risks. After the surgery, you could possibly have, say, hernias or small bowel obstruction. This is because scar tissue can cause narrowing or partial obstruction of your small intestines. It doesn't happen with the sleeve gastrectomy or the gastric band. Now, this next one is something to consider, although rare. It's called anastomotic leaks. This is when possibly food from your intestines leak into your sterile body cavity. And if this goes untreated, it can possibly lead to sepsis or even death. Again, it's rare, but it's something to consider. Now, the next side effect that is not as rare is called dumping syndrome. Now, this can happen when a person starts eating solid food after being on liquid food for weeks, and the food is in greater volume than the stomach can hold. The symptoms of dumping syndrome include cramps, rapid pulse, perspiration, and dizziness. This includes extreme anxiety and really panic. The person turns this awful pale gray color and they have little beads of sweat on their face. The process that makes this happen is like this. Simple carbohydrate is dumped into the intestines before it is ready to be absorbed, and it attracts water to equalize the osmotic pressure. So water is drawn in from the bloodstream to balance the solid food. This causes a rapid drop in the bloodstream fluid, and the blood pressure drops sharply. The result is cardiac insufficiency and low blood pressure. When the simple carbohydrate gets into your intestines, it's rapidly absorbed, causing a sharp rise in blood sugar. So you've got a high blood sugar with insufficient fluid. This causes a spike in insulin, which results in a sharp drop in blood sugar. So the cold sweats and dizziness comes from hypoglycemia. It's what we in the nutrition biz, or maybe just me, call a roller coaster blood sugar, straight up and down and up and down. In addition to this dumping syndrome, there is steatorrhea, or fat in the stools. This is because key enzymes from the pancreas that usually break down fats have been cut out. And that is because the enzymes move into the small intestines, which are not there. Now, another issue is obviously malnutrition. In particular, iron deficiency anemia, which is almost always a problem. Also, vitamin B12 and folate deficiencies. And we have diarrhea from, among other things, lactose intolerance. And that happens because the enzyme lactase that breaks up the milk sugar is in the intestines. And in some cases, that part of the intestines has been removed. We also have bile reflux, if that part of the intestines has been removed, gallstones, hair loss, body aches and feeling cold, and last but not least, mood swings and hormonal swings. Now, as I look at all this, I imagine that you're thinking, hey, Gene, it doesn't sound like you're into this surgery at all. And lo and behold, I'm not a cheerleader for these more dramatic surgeries. And I know that with all the information about side effects on TV commercials, we can sometimes get numb to a listing of symptoms that most of us think we're not going to get. But you're right in thinking that I'm hesitant to support this. Having worked with many of these people, I know firsthand how much these people are suffering when they do get the side effects. It is certainly something to consider when weighing the pros and cons. Now I'm going to stop here, and I'll take up the pros and cons in more detail in part 2. Deep down, I know this is a difficult decision that every individual can make with their own needs and health in mind. But I just cannot emphasize enough that this is a life-altering decision, and certainly not as easy as it may seem when weighing the alternative of slow, steady weight loss with reduced calories and exercise, etc. Anyway, I'll talk more about that in part 2 of the series. That's all I have for you today. Be well and stay tuned next week for another edition of Healing Outside the Box.